All right, put on your seatbelts, everybody. Time to talk about gastric polyps, which I have a fetish about. All right, so we're gonna look at some of the key forms of gastritis and the polyps with which they're associated. We're gonna talk about oxyntic versus foveolar gastric hyperplasia, very important concept. And I'll show you a couple of my favorite polyps. So let's start out with the basics. Atrophic gastritis, H. pylori associated, the most common, versus autoimmune. So number one, so of course, most patients who have H. pylori infection are actually not symptomatic. Some have dyspepsia. Everybody in this room who's older than 50 remembers that they all had duodenal ulcers and peptic ulcers because we were too dumb to treat them. After many years, of course, we see loss of gastric glands and intestinal metaplasia. And of course, this sets up the patients at risk for intestinal type adenocarcinoma and of course, mucosa-associated lymphoid tissue lymphoma. There's also probably a link to autoimmune gastritis in the susceptible host, much like eating bread gets you set up for celiac disease in the correct setting. All right, so I think everybody in this room knows how to diagnose H. pylori gastritis, but I'll put it into words. Oh, the silly thing doesn't work. Okay, that's fine. So in H. pylori gastritis, so you tend to see a superficial lamina propria infiltrate. And of course, everybody knows to look for neutrophils in the mucosa. Oh, now it's decided to wake up. Here's some neutrophils, and those of you who are awake and in the front row can probably see a few organisms here. Of course, after many, many years, one can get intestinal metaplasia. This is a special preparation called Stemmermann solution. It's poured onto the surface. It's an alkaline phosphatase solution, and everything that's intestinalized turns red. So on the right of the image, you can see the gastric body. Down here would be the duodenum. Here's a cancer, and it's arisen kind of at this junction of the body and the antrum in an area that's intestinalized. So MAG, of course, standing for Metaplastic atrophic gastritis. It wasn't, though, shockingly, until 2008 in one of the holy books of medicine, The Lancet, that it was actually proven that you could prevent gastric cancer by eradicating Helicobacter pylori. This was a Japanese study, and what they did is they took all these folks who walked in the door who had H. pylori and little bitty cancers that could be treated endoscopically. They eradicated half of them, and they didn't eradicate the other half. They had to abandon the study at the 3-year mark because it wasn't ethical not to eradicate the Helicobacter pylori in the patients who hadn't received treatment because they were getting repeat cancers. A similar thing was shown in another holy book of medicine, the New England Journal of Medicine, 10 years later. Slightly different thing. These patients all had an attempt at eradication that wasn't successful in some of them. And you can see that study had to be abandoned because of the increased cancers in the folks who still had the Helicobacter. Pretty amazing that we didn't prove it until fairly recently. Now let's flip over the record and play the other side and think about autoimmune gastritis. So you can see in a cartoon on the right with the red where the intestinal metaplasia is. If you have H. pylori gastritis and you get intestinal metaplasia, initially it's right in that junction between the antrum and the body, which is why we like our clinicians to biopsy the incisura, this junctional area, and then over time it spreads. Not very many people end up with intestinal metaplasia throughout the body if they have autoimmune or if they have H. pylori gastritis. And of course, the flip side is the autoimmune, where the intestinal metaplasia ends up mostly in the gastric body. All right, so these are some more of these gross specimens. By the way, I got them from the late John Yardley, who was, of course, a pillar of GI pathology in the Johns Hopkins community. So you can see these opened up stomachs. Here's an H. pylori carcinoma, and you can see that the intestinal metaplasia is at the junction of the body and the antrum in which the carcinoma arose. And here in this patient with autoimmune gastritis, the antrum looks pretty good, and the body is where we see the intestinal metaplasia. So it's a shame that part of the slide is cut off, but that's okay. So autoimmune gastritis is an immune condition in which there are autoantibodies to parietal cells, sometimes intrinsic factor. And at the time of diagnosis, you generally don't see the bugs. If Gastritis is well developed. You only see the pathology in the body with extensive metaplasia and mucosal thinning, and the antrum looks pretty good and often has a hyperplastic appearance. The endocrine cells, though, for the residents are the key finding, and hopefully you've been taught about that here. So in the antrum, you might see some G cell hyperplasia because the G cells in the antrum secrete gastrin, and so they're needing to say, hey, stomach, put out some acid to digest the patient's food. Oh, but there are no parietal cells, so there's no acid put out from the body. So the antral G cells say, oh, we'll work a little harder and make some more gastrin. Nothing happens. But the gastrin works by impinging on the enterochromaffin-like or ECL cells in the gastric body. So those little guys are stimulated. But of course, it doesn't help because what they normally do is put out histamine that makes parietal cells secrete acid, but there are no parietal cells. So we have an interrupted feedback loop and the ECL cells become proliferated. That you get more of them, they get juicier, etc. All right, so this is from an autopsy. I believe the patient passed away in a motor vehicle accident, and she proved to have autoimmune gastritis. Notice that I say she, it's a female predominant condition. And her gastric body is so thin that you can see every little blood vessel, whereas you can still kind of see the folds in the antrum. Okay, it's an old, nasty, fixed autopsy stomach. All right, so here's a biopsy. On the left, same magnification, same lab, we can see some autoimmune gastritis. It's the body. On the right, normal oxyntic mucosa with the parietal cells and chief cells down here, and it's thicker than the mucosa in the patient with autoimmune gastritis with loss of parietal cells. Okay, so here's what we might see in biopsies from a patient with autoimmune gastritis. Here's the antrum. Hopefully the residents all recognize that there's a little bit of chemical or reactive gastropathy with these corkscrew-shaped glands with a little loss of mucin. And you can probably make out some slender little smooth muscle bands in there. Oh, joy. Here's the body, same patient. It's disorganized. It has absent parietal cells and it has intestinal metaplasia and so-called pseudo or pyloric metaplasia, whatever you prefer. These look like antral glands. The trouble is that they don't have G cells, so some people say there's pseudo-pyloric metaplasia. Or you can say it's antralized. Look where the inflammation is. It's down at the bottom, not at the top, like you see in H. pylori gastritis. Something that you typically see in patients with autoimmune gastritis is pancreatic metaplasia. If you see pancreatic foci at the junction of the esophagus and stomach or down at the other end, it's usually heterotopic, but in atrophic body, it's considered metaplastic. So it's very cute. And we get to hear about pancreas later, so we have to do a preamble. All right, so if you have fancy immunostains and you want to set yourself up to prove it, you can do a gastrin stain and it'll stain the G cells. And notice how orderly everything is. The G cells are kind of all in a line here between the antral glands and the foveolar stuff where the pits are, living in peace and harmony. If you don't have gastrin because you're in a small place, a chromogranin will do the same thing. You do it on pattern. There will be all these little G cells staining and a few other little guys. On the other hand, in general, there are no G cells in the body. If the biopsy is from the transitional mucosa, you might see one or two. So like here's one. I don't think that's one, but they're mostly gone. So this ain't real antrum, even though it looks like it. Okay, this is a chromogranin on the body, and it is showing nodular enterochromaffin-like hyperplasia and areas of linear, 5 or 6 of these little puppies in a row. And here's one on very high magnification. So very easy to spot. And sometimes you can even see it on the H and E. I usually can, but not always. Okay, so what happens if you have autoimmune gastritis? Well, you have achlorohydria or marked hypochlorohydria. You might not absorb vitamin B12. And so after many years, you can get pernicious anemia. That's a neurodegenerative condition. You might have high serum gastrin for reasons that we discussed. And your risk of gastric carcinoma is increased through the metaplasia dysplasia carcinoma sequence. And you probably aren't going to have an ulcer because you have no acid. So when I was in school, and even when I was a junior attending, I was taught that this was a disease of people who look like they come from Minnesota, pale people with blue eyes. But no, that is wrong when you actually look at data. It's an equal opportunity disease racially, but it's definitely in favor of women, regardless of what these women look like. It has a huge female predominance. Okay, so what separates from the men, separates the men from the boys and the women from the girls is picking out the evolving autoimmune gastritis. And I enjoy picking those out. In these patients, they haven't quite lost all their parietal cells. They just have apoptotic patchy damage to their parietal cells. And they'll have little pockets of pyloric and pancreatic metaplasia. You can usually detect a little bit of enterochromaffin cell hyperplasia. Presumably, the decreased parietal cell mass makes the patient's G cells work harder. What's really cool is that occasionally you can spot H. pylori. I can never see it in these patients on the H&E, but if I see even one neutrophil, I'll get a stain. There are some studies that suggest that if a patient still has H. pylori and you eradicate it, you can slow down the parietal cell loss. So here's such a case. This is let's say Mrs. Smith's antrum, but she could be Mrs. Garcia or Mrs. Swenson or whatever name you want, Mrs. Khalifa, whatever origin the patient might have. And here is her antrum. And you can see there's a little bit of reactive gastropathy. And here's her body. And she does have plenty of parietal cells, but some of them are being attacked. There's one here being attacked, and there's a batch here being attacked. And notice that there's more inflammation at the bottom than at the top of the biopsy. So this is just another image showing this attack on parietal cells, this vicious attack. Here's one that's apoptotic. These guys are being picked on, and we're in the body. And in this particular patient, this is the chromogranin stain, and you can see this nice enterochromaffin-like cell hyperplasia that confirms that there's, in all likelihood, hypergastrinemia because of parietal cell loss. And this particular patient had H. pylori. Again, the data on what eradication does or doesn't do are not that great. They're more epidemiologic. Okay, so just lining them up for a beauty contest. Let me move my ugly face so you can see it better. So this is your H. pylori gastritis with this band under the surface. And here's your autoimmune with kind of full thickness inflammation. So you can actually pick this out pretty well in the H&E. So what do we need to assure? Make sure you know how to diagnose autoimmune gastritis. I certainly wasn't taught. I wasn't able to do it until an embarrassingly recent time. And the other thing is that sometimes clinicians don't know what to do if you report autoimmune gastritis. So I've begun to report autoimmune gastritis / pernicious anemia pattern, and clinicians know what that is. So you wake them up. So in the biopsies that were in-house at Johns Hopkins when I was there, autoimmune gastritis was seen in about 2% of our stomach biopsies, not selected for just folks walking in the door. Curiously, we studied this formally a number of years ago and noticed that in our population in Baltimore, that in fact, amongst the Latinas, there was about 3% autoimmune gastritis, but there were insufficient Latinas in that population to know whether it was coincidental. On the other hand, I have real data now in Miami because everybody is Latina, and it's about 4.5%, and I have no idea why that is, but it's an observation. But do remember to think of autoimmune gastritis if your biopsy that's supposed to be body looks like antrum and it has bottom-heavy inflammation. Okay, so this is the kind of stuff I put out in a report. I just get the word pernicious anemia in there, and then I point out an important thing. So patients with autoimmune gastritis often present with iron deficiency anemia because they don't absorb iron because of their high gastric pH. They also, of course, are prone to neoplasms. So I point that out. Okay, now something that's been on gastroenterologists' lips lately is what is incomplete versus complete intestinal metaplasia, and do they matter? And unfortunately, our gastroenterology societies are starting to make a fuss about this. I personally think it's not that worthwhile in the US population, but it's becoming stylish. The main thing is that epidemiologically, the incomplete type, in other words, it can't make up its mind whether it wants to completely look like intestine or sort of half look like stomach, half look like intestine, is epidemiologically more likely to progress to cancer. The complete type is more common in gastric mucosa with intestinal metaplasia, whereas, for example, in the esophagus, we usually see the incomplete type. So this is just a beautiful image in a patient who has both in one field. So the complete type recapitulates small bowel, brush border between which there are goblet cells. Incomplete type, goblet cells between which are gastric foveolar type cells. So you don't have to stain it, but if you happen to, you get this nice pink in the foveolar type cells with the goblet cells between, whereas in the complete type, you have the brush border with the goblet cells. So it's actually quite easy to do on the H&E. So I have a feeling in the next few years, there's going to be tremendous pressure. The trouble is that I know when I see these cases, there's often both. And so in theory, you'd want to quantitate. So it's a little bit of a bogus thing because the colleagues have other ancillary ways to look at this, but it will be coming and it's very easy to tell them apart. Okay, so now going backwards, if somebody has autoimmune gastritis and after many years of this hyperplasia of their endocrine cells, they get neoplasms. And of course, we call those carcinoids, or I call them carcinoids because I'm old, but we're supposed to call them well-differentiated neuroendocrine tumors, or NETs. So let's look at a case. A partial gastrectomy was performed for cancer in a 55-year-old woman with a history of type 1 diabetes. So in other words, she's a girl who likes to get autoimmune diseases. So here we go. Here is her resection, which was a lot more than she needed, but that's neither here nor there. And this was her gastric body cancer. So you can see here's the cancer. And look at the flat mucosa adjoining it. It's got bottom-heavy inflammation, and this neoplasm, of course, is right at the junction of the mucosa and the submucosa. So you already know at this magnification that it's probably a well-differentiated neuroendocrine or carcinoid tumor. This is a different case, but showing similar findings, and you can see this, this neoplasm. It's a little bit scary because it's making tubules and even has a few nucleoli, but this is a well-differentiated neuroendocrine tumor. This is higher magnification of the junction between the neoplastic and non-neoplastic component. And you can see, even though it's gastric body, there are no parietal cells. So this is kind of cute. This is a Ki67 synaptophysin combo. The synaptophysin has the red chromogen as opposed to the brown diaminobenzene. And you can see that this is obviously a NET. You can see there's a lot of reactive proliferation in the non-neoplastic mucosa, and there probably wasn't much in the neoplastic tumor. Once you get an eye for it, you can spot enterochromaffin-like hyperplasia that's well developed in such cases. And I've indicated a pocket of it in this image. Remember, this is gastric body, so you can see all the intestinal metaplasia. This is that same peculiar preparation, just showing you that Ki67 highlights the proliferation zone. And then you can see that these nodules are neuroendocrine type things. So there's a, oh, wow. So it's missing, I don't know how to move this. The question at the top is, when does it stop being hyperplasia and become a neoplasm? And there's a huge literature on this that is really interesting as far as when does something become self-proliferating and neoplastic, but it's really of no practical value. The reason it's of no practical value is that these type 1 carcinoids essentially never kill anybody. They occasionally metastasize and the patients just perk on and on and on. They're extremely indolent. So in daily practice, it's really pointless to measure minute lesions because they don't hurt anyone, even as full-fledged carcinoids. However, some people do use this tiny 0.5 millimeters as a cutoff for when you start to say it's a carcinoid, and I'm using the old terminology. I'm so lazy that if the endoscopist sees a nodule and I see a neuroendocrine proliferation, it's a carcinoid, but the patient's going to be fine. All right, the trouble though with type 1 well-differentiated neuroendocrine tumors arising in hypergastrinemia from autoimmune gastritis is they can have really weird morphology. So this is one, richly vascularized, and if you're like me, you might find yourself wondering if you're dealing with some sort of a mesenchymal tumor. So you sometimes end up staining them for hand holding because you really just don't know. One thing that's a pitfall with these so-called type 1 carcinoids is if you do a Ki-67 on them, about 20% of the time, you will get a proliferation index that's in line with a grade 2 well-differentiated neuroendocrine tumor, but they don't behave like it. And then you have to write a long note. So I avoid doing it in the first place. But as you know, sometimes our colleagues can be a bit rigid about ticking the boxes. So if you do it and then you see this extra proliferation, you have to write a note. There's actually a nice paper on this by Noam Harpaz, H-A-R-P-A-Z, who'd been at Mount Sinai. He may be retiring around now. Okay, let's look at another case. This one's for the residents. You'll need this for your exams, but the rest of us encounter it once in a while. Slide A is from the duodenum and B is from the stomach. What syndrome can we think of? All right, so here's A. We're in the duodenum. There's a little bit of gastric mucin cell metaplasia, and here's something that looks like a well-differentiated neuroendocrine tumor. Here it is at higher MAG. And here is the stomach nodule. Okay, you can't really tell what kind of mucosa is around it. It's probably body. There might be a hint of it down there, but it's kind of inflamed, but it's right by the nodule. And at higher magnification, this nodule looks neuroendocrine, but the cells are a bit different from what we just looked at. And this is a gastrin stain on the duodenal one, very strongly positive. This is a gastrin stain on the stomach one, very strongly negative. There's some background staining in some of the inflammatory cells, but the tumor is negative. So hopefully the residents have all figured out what this is. Sorry, I don't get paid to sing. So this is just Zollinger-Ellison syndrome with a duodenal gastrinoma and then a gastric type 2 carcinoid of enterochromaffin cell type. And this is, of course, from the hypergastrinemia from the duodenal gastrinoma. So really, really cool. So back in the day, before everybody popped proton pump inhibitors like candy, this is what we would see with Zollinger-Ellison. We would see this massive hyperplasia of the oxyntic mucosa. Here, it's just as thick as the muscularis propria. And it was very impressive with giant folds. And it was pretty easy to spot if you were the gastroenterologist. Here's a higher magnification of the one I just showed you. And you can see that the parietal cells go right up into the surface. So there's no sort of Grent zone akin to what our dermatopathology colleagues know about. So it's kind of a clue. Here's very high magnification. And you usually see a break and you don't see these parietal cells way the heck up almost at the surface. This happens to be a lymph node metastasis from the gastrinoma that produced the stomach findings we just saw. And I'll talk a little bit more about that from the small bowel side later today. So here's what a modern gastrinoma looks like. And you really have to have your little antennas up. I was lucky enough that I did on this case, but gosh, I could have missed it. I was crowing when I didn't, which probably means I screwed something up the next day. All right, so I got this biopsy from the patient's gastric body. And I noticed that it had an erosion, and I noticed, oh gosh, these parietal cells are kind of high, but oh, come on, patient couldn't possibly have anything. So I was kind of concerned. And then I got the patient's duodenal biopsy, and there was also an erosion there, and it looks kind of, what's the right word? Reactive. It doesn't look very happy. And then I was very confused, and I looked and looked, and then I found this. See it? And there's more of it. And apparently the endoscopist had encountered a firm area. And there's a gastrin stain. So this is what modern Zollinger-Ellison looks like. And it's sneaky and tricky. And I don't even want to think about what I screwed up the next day. Okay, so that's the so-called type 2 carcinoid. Remember, we're in Zollinger-Ellison, there's hypergastrinemia, and then you get a little stomach nodule. Then there's the type 3 neuroendocrine tumor of the stomach. So there's no autoimmune gastritis, no gastrinoma. So in other words, no hypergastrinemia. And these are the bad dudes. The first two are not bad dudes. So these are more aggressive than type 1, and about a third die of disease, and there are metastases at presentation in over 2/3. Remember, the ones associated with autoimmune gastritis almost never metastasize, and deaths from such things are truly exceptional. So I'm an old lady. I've been doing this a long time. I've only seen 2 type 1s with local metastases, and the patients did fine. So it's really, really rare. And I've only seen a handful of type 2s because, of course, they're in Zollinger-Ellison. But type 3s are bad. Of course, the data on type 2s aren't very good because the patients tend to die of their gastrinomas. Okay, so this is a type 3. This is an endoscopic mucosal resection. I know not yesterday, but the day before, some of the residents have seen this very picture. So this tumor lives right at the junction of the mucosa and submucosa, but now we have intact background oxyntic mucosa. Those guys are happy. This thing is just growing from wherever it wants to. So here's a higher magnification. I'm showing you intact oxyntic mucosa with parietal cells. And this tumor, these are the naughty ones. And just like the type 1s, they can have weird morphology. This is making these peculiar tubules. You might think of spread from a lung carcinoma. They can really send you down a garden path. And here's another one that's a real sneak ball. Feel free to use technical terms. So here it is. It's an intact oxyntic mucosa, and it's really quite spindly. And a poor colleague had done a kit and inadvertently diagnosed it as a gastrointestinal stromal tumor. Obviously, that would be weird for it to be so mucosal predominant. But boy, I have great sympathy for the colleague who got fooled by this. And here it is at higher magnification, and it really does look very spindly. So just a little pearl is that gastric neuroendocrine tumors are just weird looking. That was a technical term. Okay, now there are a few wrinkles in this classification of stomach so-called carcinoid tumors. The type 1s, as we discussed, the ones in autoimmune gastritis are exquisitely indolent, and the type 2s are probably indolent. Generally, the type 3s are bad, but there's a very cool recent paper. This was out of the University of Pittsburgh, although Kathy Ma has moved to St. Louis, Barnes. And there's this subset of things that at face value look like type 3 carcinoids with intact oxyntic mucosa, but the patients have been on proton pump inhibitors for a jillion years, and they have a little bit of they have this sort of low-level hypergastrinemia. And these patients do somewhere in between the type 1s and the bad type 3s. They seem to do better than the usual story. So it's definitely something worth digging around in if you encounter one. And then there's the rare so-called type 4 carcinoid, which I've probably missed. And I'm not quite sure what the clue is to identify it, but these patients have hypergastrinemia related to defects of acid secretion by their parietal cells. And they probably mostly have inactivating mutations in the gene that encodes for the potassium hydrogen ATPase pump in the parietal cells. So I think they're really rare, but I would be willing to bet that I've missed one. And that's the so-called type 4. But I think this is kind of the cool one that you might actually encounter in practice. Okay, so we talked about Oxyntic hyperplasia. I'd like to flip over the record and play the other side with a little bit of commentary on foveolar hyperplasia, which will then lead us into other lumps and bumps. Okay, so those of you who are a little older, remember Ménétrier disease in its pure form, not the fake form caused by cytomegalovirus in children. You see this massive gastric foveolar hyperplasia, and it just pours out this nasty, goopy, mucousy protein, and then the patient becomes hypoproteinemic because their stomach won't stop drizzling all their protein. And then the background mucosa is really uninflamed, but very edematous. And you usually see it in the body and fundus, not the antrum. So if your clinician biopsies the antrum and says, rule out Ménétrier, your clinician is probably a little naive, but that's okay. But you can't diagnose it unless you know what's going on endoscopically. You need to know that the patient's got protein loss and peripheral edema and this nasty, bumpy gastric body with abnormal, flat-ish mucosa. So let me show you. This is from Ménétrier's original paper. Isn't that pretty? So cute. And this is a case, a real case, and it's old. And this was from the late Dr. Yardley, because now there's targeted therapy. So you're not going to see this. So this poor patient had to have a gastrectomy. The antrum is spared. There's this massive foveolar hyperplasia. Here's another one. I'm just showing off that I have these pictures. So this is the antrum, looks regular, and then this hot mess of a gastric body. Here it is on the cut surface of the fixed specimen, and you can look at the muscularis propria, and then there's just this hot mess. That's a technical term, right? Okay, so, but this is what you see under the microscope, and it's pretty darn boring. You basically get something that kind of looks like a hyperplastic polyp of the body. The parietal cells have been squashed down mostly out of existence. But if your colleague gets you a biopsy like this, you're going to call it a gastric hyperplastic polyp 24/7. The good news is that usually if you get a biopsy of this, the gastroenterologist or whoever scopes the patient is scared. They know something's off, and they'll rush it or they'll fuss about it or call you. So you usually don't have to get fooled, but you can. So curiously, many years ago, our colleagues worried, I think it was at Duke, they realized that the pathogenesis of Ménétrier might have to do with things in the EGFR pathway. And in fact, you could make transgenic mice that overproduced a member of that pathway, transforming growth factor alpha, and you could turn them into Ménétrier mice, and they would have foveolar hyperplasia and lots of mucin just pouring out of their stomachs. And of course, TGF alpha is in the EGFR, epidermal growth factor receptor family. And so it's all just along that pathway. And sure enough, these colleagues, and you can see there are a few pathologists, Kay Washington, Jim Goldenring on these papers, who realized that, hey, you can just use anti-EGFR medicines to these monoclonal antibodies to settle down Ménétrier disease. And of course, back in the day, they were called Erbitux. Now we call it Herceptin, but all the sort of generations of the same types of molecules. So that's kind of cool. So you won't see the resections these days. Okay, so we're going to switch gears. Now we're in polyps. So a biopsy was performed of a gastric polyp, and I diagnosed it as a hyperplastic polyp. The gastroenterologist called me and she laughed at me. Thanks. All right, let's look at what I did wrong. Okay, so here it is. So it's got some foveolar hyperplasia. Now there is this funny smooth muscle, but I assumed it was tangentially embedded and prolapsed. Ah. Here it is at higher magnification. You can see a little granulation tissue at the lower right, and you can see this nice smooth muscle. And of course, this was a gastric Peutz-Jeghers polyp, and the colleague hadn't deigned to tell me that the patient has Peutz-Jeghers syndrome and that the flat mucosa looks marvelous. So of course, I just had no chance. And the reason I had no chance is because you just can't tell in the stomach how to diagnose Peutz-Jeghers polyps. All right, so just to refresh our memories, PJ polyposis, Peutz-Jeghers polyposis, is an autosomal dominant condition. These patients have germline mutations of the LKB1 or STK11 gene, not all of them, but a bunch of them. And I think everybody remembers from school that they have polyposis, funny pigment on their lips and inside their mouths. They can have it on their palms, eyelids, genital areas, and in funny places where you don't normally have freckles. And it fades with puberty or with advancing years. So you might not see the stuff around somebody's mouth if they walk in the door as an adult. So these are two little children who have the pigmentation of Peutz-Jeghers. And this child has very pale skin, so it's easy to see the peculiar pigmentation on the lips, whereas this child has darker skin, so it masks all these areas. So then you can see the colleague turn the child's lip up so that you can see the pigment inside of the child's mouth. And that pigment in the mouth does persist better into adulthood. This is a gastrectomy from a patient with just massive Peutz-Jeghers gastric polyposis. Very uncommon, but you can occasionally see it. So the problem, though, with gastric Peutz-Jeghers polyps is they don't show perfect morphology like the ones in the small bowel. You kind of see this sort of messy version like what I just showed you. Once in a while, they are perfect, but no, usually they aren't, and you would be crazy to make a first diagnosis of Peutz-Jeghers syndrome on a stomach polyp biopsy. You don't want to do that because you could easily be wrong. And as many of you know, this condition carries a greater than 90% lifetime risk of cancer, not the polyps themselves, but overall, pancreas, breast, etc. Okay, so this is what they look like in the small bowel. A monkey can diagnose this. This one was resected because of intussusception, but we have this beautiful arborizing smooth muscle, site-specific mucosa, very easy to recognize. Oh, sorry, I accidentally put those there. Oops. This is a perfect stomach gastric or a perfect gastric Peutz-Jeghers polyp with the arborizing smooth muscle. You can see that the colleague who resected it did a beautiful resection. The stalk sort of, if you will, is here. And then the adjoining mucosa is quite normal looking, but not every gastroenterologist gives you such a specimen. If you had something like that, you would call it a hyperplastic polyp 7 days a week. Here's another one that followed the rules, and you can suggest the syndrome. And here's yet another one that follows the rules with these cords of smooth muscle separating site-specific nodules of mucosa. Here's mine, which I misdiagnosed. After I did this, I actually have such a big ego about these things that I thought, okay, I need to learn to do better. And here's a small bowel one, and you can see how perfect it is. So then juvenile polyposis is a condition in which some families have an autosomal dominant germline mutation in a different gene, a DPC4, also called SMAD4, on chromosome 18. These patients can have polyps limited to the colon, or they can be generalized, involving the colon, small bowel, and stomach. And then there's a subset of patients that have juvenile polyps pretty much restricted to the stomach. And those are the ones most likely to have the SMAD4 mutation. So this is a resection from such a case. Actually, I pilfered this image from Atul Singhi at the University of Pittsburgh. Well, he emailed it to me, but I photoshopped it and made it prettier. And this is what you might see in a gastric juvenile polyp. It kind of has the features of a juvenile polyp. Oh, it's not letting me move me. Okay, that's all right. But it has a very smooth surface and all this edema and these cystically dilated glands. So this one's pretty characteristic of what a juvenile polyp looks like, and it happens to be in the stomach. On the other hand, just gastric hyperplastic polyps that tend to arise in the background of damaged mucosa kind of have these fake villi, this more villiform surface, and they really don't have so much cystically dilated glands. But in any given case, it can be really impossible to separate them. This is a gastric juvenile polyp in an Italian patient. That was a no. All right, and this is another gastric juvenile polyp, and I just draw your attention to the fact that it's multilobulated, has a smooth surface, and has arisen in uninflamed mucosa. And here's its sort of sister lobule, but you'll notice the smooth surface. This, on the other hand, is a polyp from the stomach of a patient known to have juvenile polyposis, and I cannot distinguish it from a hyperplastic polyp. And that's the story much of the time. So I became very concerned, oh gosh, maybe if we do better, maybe if we look more carefully, we can figure out what's the hyperplastic polyp and which are the syndromic polyps. And unfortunately, you really can't tell. There's some clues. If you have biopsies of flat mucosa, you might see atrophic gastritis in the background, and that tells you it's probably hyperplastic. And then, of course, you can look for that villiform appearance. But the dirty laundry is that you kind of need to know the patient has the syndrome if you're going to make a polyposis diagnosis. And you don't want to make the first diagnosis in the stomach. So, oh gosh, it doesn't show. Because the top line says the different types of polyps. These were criteria that some of my colleagues and I came up with. And this would have been for Peutz-Jeghers. This would have been, is there a way to make this stop? Oh, thanks. Let me get out of your way. Oh, magic. All right, so you can see that we came up with these criteria. Do they work? Well, a little bit. Oh, it's not letting me advance it. So this is actually from a paper by Dora Lamb-Himlin, and you can see that this is how accurate we were. So we did pretty well if the polyps were giant, but if they were small, no, we did a terrible job. So just, it's the way it is. All right, now there's some other peculiar non-neoplastic polyps that look a bit like hyperplastic polyps. And the key one is one that I've only sort of thought about recently, and those are the ones associated with portal hypertension, obviously in most populations from alcoholism. And they look very much like hyperplastic polyps, but it's an association you might see. And when patients have portal hypertension, sometimes they'll have various procedures to mitigate the blood flow issues. And after they have those procedures, you can actually see these peculiar post-procedural polyps. And you can even see a polyposis in the antrum and in the small bowel, and sometimes even in the gastric body. And the best paper on that is actually referenced here. And these images are in fact from that paper. I did not acquire those, but it's an interesting paper from the Canadian Journal of Gastroenterology and Hepatology. So here's a case that came across my desk. This is just the patient's flat mucosa who had portal hypertension, and you see vascular ectasia, and we all kind of know this in the lamina propria, but then the patient had several of these peculiar polyps, and the surfaces of them look just like hyperplastic polyps, and they also had this vascular ectasia. So if you see something that looks like a bunch of hyperplastic polyps, usually in the antrum, do check and see if the patient has portal hypertension. And this is another one that was really dramatic that arose in otherwise unremarkable flat oxyntic mucosa in a patient with very dramatic portal hypertension. Okay, large gastric body polyp in a woman who wasn't born yesterday with many years of autoimmune gastritis. Here it is. This is my obsession. Looks a little bit like a hyperplastic polyp. I used to misdiagnose these as hyperplastic polyps. This is a different case at high magnification. And this is, of course, a pyloric gland adenoma. And let's close with a few comments on stomach dysplasia and polyps. So we can, if we look at gastric, we'll call them adenomas for now, in a Western population, we tend to see intestinal type adenomas. You could also call them polypoid gastric dysplasia with intestinal differentiation. There's the foveolar type, there's the pyloric gland type, and then there's the more rare gastric chief cell or oxyntic gland adenoma, and that's much more rare, and it's sort of an evolving concept. GNAS mutations are seen in both pyloric gland adenoma and oxyntic gland adenoma, and there's this very interesting association of the pyloric gland adenoma with familial adenomatous polyposis, particularly the very rare GAPS or gastric adenocarcinoma proximal polyposis syndrome. So kind of an interesting evolving set of understanding. But you see GNAS mutations in pyloric gland adenomas, whether they're sporadic or syndromic. Our European colleagues, though, don't like the idea of calling gastritis-associated polypoid lesions that are dysplastic adenomas. They want us to think of them, and it's intellectually correct, the way that we think of inflammatory bowel disease-associated lesion-forming dysplasias. The old term was DOM, the new term is just a visible lesion. And it intellectually makes sense, but of course, old habits die hard. And so you'll hear from your gastroenterology colleagues about the MAPS criteria, management of epithelial precancerous conditions and lesions of the stomach. And that's MAPS. And MAPS says, no. If the patient has gastritis and metaplasia and there's a bump and it's taken out, it's a lesion, not an adenoma. I'm used to calling them adenomas, so I tend to use the terms interchangeably. So when this first became popular, it's like, okay, so if a pyloric gland differentiated polyp is in a patient with autoimmune gastritis, that's not an adenoma, but the same patient in flat mucosa that's normal has an adenoma. So I'm a little slow. Same story with intestinal differentiation. So this is an example of a lesion that made a polyp. And you can see it looks very much like a tubular adenoma of the colon, except for this little minor detail of the gastric foveolar glands and pyloric type glands down here, but it made a bump. And this is a PAS Auschen blue on this polyp done for fun. And I think it shows some intestinal metaplasia here. I thought it had some goblet cells in the polyp, but I'm not spotting them now. But here's the patient's flat mucosa. So you can see that it's damaged and has a lot of intestinal metaplasia. So then that prior lesion wouldn't intellectually be an adenoma, even though it's a bump, it would be a visible lesion that can be taken out. And here's the PAS Auschen blue from that. And you'll notice that there is complete intestinal metaplasia. Oh, but over here, there's incomplete. So in a way, that whole thing is sort of silly to me. Anyway, this is the real adenoma of the stomach. This is the oxyntic gland, or I'm sorry, the foveolar adenoma. And you can occasionally see this same phenomenon on top of fundus gland polyps. So you have elongated nuclei, but there's no metaplasia, there's no bad stuff in the background, there's just this polyp, and the surface has only foveolar cells. This is the true adenoma of the stomach in our population. Right? Just like in our colon, your flat mucosa will be normal, and then you'll get this polyp, and it's just biallelic inactivation of, the APC gene, and you get a polyp and you're done. Well, this is the analogy in the stomach that has a lot less real estate. So here's another one. This one is the same phenomenon, but sitting on top of a fundus gland polyp, but it's clearly dysplastic, but it has only foveolar cells. There's no metaplasia in the background. Something like this has essentially no risk for progression to carcinoma, and the colleague doesn't have to do anything special for follow-up, unless, of course, the patient has familial adenomatous polyposis. And here that is at high magnification. You still have your apical mucin cap, no metaplasia. And here's a PAS, just showing that phenomenon. You certainly don't need to do it. These are illustrative images. Pyloric gland adenomas, to make a bit more commentary, account for about 3% of stomach polyps once you take out the very common fundus gland polyps. And they have a huge female predominance and tend to arise in the setting of autoimmune gastritis because you get pyloric metaplasia and then you get neoplasia. So this is another one. And the features include ground glass cytoplasm without good mucin, and a monolayer of nuclei and closely packed tubules. Here's another one, same thing. If you do a PAS Auschen blue on these, you get this kind of smudge in the cytoplasm, but not a crisp apical mucin cap. So to line them up for a beauty contest, the pyloric gland adenoma below the surface, ground glass cytoplasm, the foveolar adenoma on the surface, with an apical mucin cap that's perfect in every cell. This is a small bowel pyloric gland adenoma that's kind of right at the junction of the antrum and the small bowel. You can get a lot of gastric heterotopia in the duodenum, and it can give rise to the full complement of gastric polyps that you can see in the stomach. So it's kind of a cool thing. So you can see on this PAS Auschen blue, you can see the apical mucin cap of the antral mucosa, and then there's really not any staining to speak of at all in the polyp in this example. If you like to immunostain things, pyloric gland adenomas show co-expression of mucin core protein 5 and mucin core protein 6. They get high-grade dysplasia and cancer in them. And to get to high-grade dysplasia in these gastric differentiated polyps, all you need is loss of polarity. Don't be looking for those giant cells that you see in intestinally differentiated adenomas or polypoid dysplasias in the stomach. The last is rare, and I'm a little guilty of the confusion in this entity. That's the so-called oxyntic gland adenoma or chief cell adenoma. These were initially described in a series under the term gastric adenocarcinoma of fundic type, even though the colleagues had benign follow-up in all the cases. And that's this early paper. And then I began collecting them, also got completely benign follow-up, and said, you know, guys, why are you calling these cancers? You're just making this too hard. But of course, in Japan, you don't get dinged on your insurance if you have a thing that's called cancer that's very indolent, whereas here you do. So we have a tendency here, I think, to call things more benign than colleagues in Japan do. However, more recently, I think cooler heads have prevailed, and this is also from a group of Japanese colleagues. And they said, well, you know, with these oxyntic gland neoplasms, just use the carcinoma terminology if it's actually atypical and invading the submucosa. So I think we've got these sorted out. Here's how they look. Surface has nothing. Then you have these beautiful oxyntic glands, and they're all these weird angulated glands that are mostly chief cells with a few parietal cells. I don't know if they're entrapped or part of the lesion. Here's one at higher MAG. Here's a parietal cell right down in it. But you can see why colleagues wanted to call these cancers initially, because they have those angulated glands. These stain with MUC6, just like pyloric gland adenomas, but they're negative with MUC5, and they usually have a very low proliferation index if you do a Ki67. Here's another one. This one is very weird because it arose in autoimmune gastritis, but it's below the surface. This one's more tubular, and these look more like pure chief cells, so kind of cool. If you do a PAS Alcian blue, there's nothing. You see no staining at all in these so-called oxyntic gland adenomas. And if you do MUC5, it's completely negative. So unlike pyloric gland adenoma, there's no MUC5. So this is the MUC6 and the oxyntic gland adenoma I just showed you. The pitfall in these is they stain with synaptophysin. So colleagues will see them and say, oh, am I missing a weird neuroendocrine tumor? But they don't stain with chromogranin. Here's one that convinced me that I was being a bit arrogant saying, oh, they're benign. And this one, as you can see, is more atypical than what I've shown you, and it's starting to squeeze down into the submucosa. So probably this one is best classified as the Japanese colleagues originally classified them, gastric adenocarcinoma of fundic type. But they do well. You have your endoscopist do a nice endoscopic resection, and the patient can be expected to have a good outcome. Here's just higher magnification of that last one. And still higher. So I just want to reiterate the consequences of autoimmune gastritis, because I sure as heck wasn't taught how to diagnose it when I was a puppy. You see atrophy of the oxyntic mucosa. A small subset of patients get pernicious anemia. These patients can have gastric adenomas of either the intestinal or pyloric type, and I'm using the adenoma term instead of the European term. Because these types of metaplasia are found, you can get the type 1 carcinoids. These patients often have hyperplastic polyps and can develop adenocarcinomas at 7-fold the rate as the guy on the street. So just to remind us, here's all the different types of polyps and the company that they're likely to keep. And boy, have we been through a lot. So hopefully you will all have a copy of this presentation so you can use this table if you wish. And with that, I thank you very much.